So thank you for being here, and on to you, Josh.
Thank you, Victor. Good morning. I'm Josh Martin, Vice President of Employee Benefits Consultant, USI. Today's conversation, we will explore the concept of narrow provider networks in healthcare. Narrow or limited networks have been around since the 1990s. Historically, they've served as a strategy for health insurers to drive patient volume to cost-efficient providers, or even negotiate better fee schedule concessions. Over the past decade, that power dynamic has shifted a bit between the payers and providers. It's equalized to a degree. The data analytics capabilities of health systems have significantly improved. And in the world of Medicare shared savings programs and commercial ACOs, advanced health systems have learned how to manage risk and take risk for populations. In Greater Cincinnati, we are fortunate to have a vibrant community of healthcare providers. And today in this room, we have representatives from each of the 5 adult health systems, and all are eager to share their perspective on narrow networks. Additionally, for an employer's perspective, we also have Chris Tarumbolo, CEO of CareSpring, to share his experience administering a narrow network solution for his employee health plan. So before we dive in, we'll do some introduction, let the panelists introduce themselves, share a little bit about themselves personally, as well as the health system or employer that they represent. We'll start with our health system panelist, and Tim Capel, I'll turn to you.
Good morning. Thanks, Josh, having been part of the panel. So Tim Capel, I am a health insurance geek for 40 years. So I've spent 32 years on the payer side, primarily with Humana. I've been with Christ Hospital for the last 8.5 years. And my focus during that time period has been around population health and value-based care. Let me tell you a little bit about the Christ Hospital. Christ Hospital is the oldest hospital in Cincinnati, 130 years. Founded by James Campbell at Compassionate Care to this community. We are 555 beds, 7 AOCs. We've got 660 physicians. And what I would say about the hospital is, I think as we think about, as Josh mentioned, in a dynamic market like this with 5 adult systems, we think our currency in the world is really around quality and around patients' satisfaction. So we rank really high, generally to top 50 hospital, both by most measures, scaling that roughly 5,000 hospitals in the US. So by my Xavier math, I'm pretty sure that's top 1%. So as we look at narrow networks and the landscape of value-based care, we think that we're very well positioned. And I might just add that for us, narrow networks also includes a component of direct contracting. So we can talk about that as a discussion.
Bill? Yeah, I'm Bill Banks, Vice President of Managed Care for St. Elizabeth. I've been there for 13 years, 15 years before that, working the payer side. So in the managed care game for 30 years or so. St. Elizabeth is 5 hospitals and 700 professional providers. We are in Northern Kentucky and now Southeast Indiana, so Lawrenceburg, Indiana now, with the acquisition of Dearborn County Hospital. We've been in the narrow network game really for 12 years or so, the very first foray in the modern era. Tim and I, when he was at Humana and I was new at St. E's, we built a product at Humana with the express purpose of, we're going to put this in our employee benefits and we're going to use it. And as it proves itself, we'll use it as a tool to get out and sell more product. So I think St. E's has as much experience in the narrow network game as anybody out there. We participate in, I think 8 was our last count of these kind of different plans. So we're always willing to talk to plans as they come in and use that as an experience. Looking forward to one correction. I know that we're not Cincinnati Hospital. We are 161 years old. St. Elizabeth is an old hospital. We'll be here in a few more years.
Tim Maloney.
Yes, I'm Tim Maloney. I'm the Vice President of Payer Relations for UC Health. I'll proudly say I have 2 degrees from Xavier, my undergrad degree in Economics and Business Administration, and a master's degree in Health Service Administration, and I have a law degree from NKU's Chase College of Law. So, and I'd like to say, as I'm getting older, I'm a Cincinnati guy. I grew up here, went to Xavier, one of the oldest institutions in the city, and the NKU Chase College of Law dates itself back to the late 1800s when it was the YMCA Law School. And so for many, many years now, I've worked for UC Health with a stint in between at St. Elizabeth. And so I guess from the age category, I thought University Hospital was maybe the oldest hospital in the city, but if it's not, it's very old. And it certainly is the teaching hospital. It's certainly the teaching hospital for the University of Cincinnati College of Medicine, which I believe is the oldest college of medicine, the first college of medicine west of the Allegheny. So at UC Health, we're Greater Cincinnati's academic health center. We're a referral hospital. We do provide certain services that aren't available elsewhere, things like solid organ transplant or a level 1 trauma center. We've got some subspecialists in the oncology area, stroke, and so forth. And so when we think about, our CEO says, and I think rightfully so, that, we're in the patient access business, which is what I tell my team all the time. What we're really about, and the best thing we do is we make the services of UC Health available to people who need them. And so when it comes to narrow networks, and I think that's all things sort of in that value-based payment pop health space, the terms aren't specifically defined, but we participated in a long time in Center of Excellence programs for solid organ transplant and other services. And when we think about any network, narrow network or otherwise, our position is we need to be a part of those networks because patients, unfortunately and sadly, are going to sometimes need the services that we provide, and we want to be there when they need them. That's kind of how we think about that. So I'm looking forward to the discussion. It should be a really good one. This is an outstanding panel. I know a lot of these folks well, and I know that I know how the expertise they have. So.
Thanks, Tim. I was not anticipating needing a fact checker, so early. Somebody pull up Wikipedia. Terry.
Thanks, Joshua. Good morning, everyone. I'm Terry Hanlon-Bremer. I'm the Senior Vice President of Employer Solutions and Population Health with Tri-Health. I'm actually a nurse by training, have been for 35 years, and I've done almost every aspect of nursing you can think of. I came to Tri-Health 15 years ago in their corporate health division, and now help with the population health work. This is exciting. Tri-Health has been on a population health journey for about 20 years, and most of our footprint is in the ambulatory space, as many of you all know. And that's where we get the majority of our revenue. And we're really here to help disrupt how financing happens within healthcare and how care is delivered. And so this is going to be an exciting topic. We've been doing this for a while. We've been recognized as a strong ACO, both in the state as well as in the nation by some of the payers. And we've been doing this for our own population of 18,000 members and have the ability now to really showcase our good outcomes around quality, as Tim said, as well as some cost savings, not just by cutting unit costs, but really by managing utilization. So looking forward to the discussion.
Hi, good morning, everyone. I'm Billie Jean Mounts. I'm the Chief Revenue Officer at Bon Secours Mercy Health. I've been with the ministry for a little over 5 years, so seen a lot of change there with coming together. Started here in Cincinnati as Mercy Health, and then back in 2018, we merged with the Bon Secours ministry. So we've been doing a lot of work, across 7 states. Here in Cincinnati, we have 5 hospitals, but across our footprint, we have 1,200 sites of care and 7 clinically integrated networks. So our CIM for Ohio is a statewide CIM. So a lot of our network management is really solving for multiple markets in the state. And so we do participate in some narrow networks. And so there's a balance there on going into those arrangements and understanding the different dynamics across the state. So look forward to the discussion today.
Thank you. And our employer representative, Chris Trombolo.
Yeah, I'm Chris Trombolo. I'm the CEO of CareSpring Healthcare Management. We're a private organization of 13 skilled nursing and assisted living buildings between Cincinnati, Dayton, and Northern Kentucky. I've been with the company literally for 21 years. So I'm a physical therapist by trade. So I'm a caregiver by trade. I grew up in the company, ran our therapy division for a while, expanded more into operations under the founder's lead, and then took over as a CEO about 6 years ago. So we are, as a healthcare provider as well, we take care of our short-term patients, which participate in all these systems networks, but then also on the flip side is we have long-term care residents. So we have to manage from a long-term care population for our residents, some of their own population health. We participate in ISNP programs and other things related to that. But on the team member side, we've always wanted to be really competitive. We understand we're a skilled nursing provider in a world of hospitals, and we have to be able to compete in our own make sure we can maintain and retain the best team members out there. So about 6 years ago, we've always participated in narrow networks from our patient standpoint, but from our team member standpoint, understanding there's a lot of cost savings opportunities. We went into more direct contracts with many of the institutions around here, from Kettering up north to the greater Cincinnati market and also northern Kentucky, making sure we have access, like if you're saying with UC, for our team members, because we advocate, we want all of our people to be able to take care of themselves and proactively take care of themselves, because we know proactive preventive medicine is the way to keep costs down. But on the flip side is, as an employer, we want to make sure it's cost effective and we get the right care, the right treatment at the right time. So we have a plan structure that is a more of a narrow network with direct contract with our team members to help them, again, save money, but also get access to great quality care in the community.
Thank you, Chris. So let's dive into the conversation. We'll start with the health system's perspective. That a lot of you have history and maybe lived through different waves or cycles of the narrow network evolution. We could start with, what is the impact of narrow networks on the health systems and the patients you serve? So let's put aside sort of the proactive strategies that you're taking to the market right now. Some of you are. Just give us the caregiver plus patient perspective. How are patients impacted, or are they at all? All of them.
I'll talk about St. Needs. In Northern Kentucky, if you live in Northern Kentucky, it's a very good chance to receive all of your care from St. Needs just because where we are. So for a Northern Kentucky employer, like a municipality or a small auto manufacturer or auto parts manufacturer, something like that, it's an easy decision for them to make because the likelihood is they're already getting most of their care from us anyway. And my bargain with them is just commit to using us for all of your care, and I'll give you my best price. Then so at the point of care, not really an issue. It's that point of sale and the point of selection when an employee has to say, I agree to never go to Christ again. That's a little scary. So I think that at the point of care, it's not a problem. It's at the point of, are we really going to tell our employees that they can't ever go to university or Christ or Mercy maybe because they're committing to only St. Needs and Tri-Health? That's where it gets scary for employees and employers. Sure.
So I think narrow networks for systems can be kind of double-edged sword, right? On one hand, you're creating steerage or nudge, push, shove employees into a particular system that you've created a favorable relationship with. So on one hand, it should produce more volume and more opportunity to manage those patients, particularly if you can get them within the primary care net, because that's, in our view, that's the secret sauce. I can talk a little bit about that later. Because that's what's going to manage trend, and that's what's going to close the care gaps and use all the analytics to get people expensive. On the other side of that, though, because particularly in a city like Cincinnati with 5 systems, this is very unique, by the way, for those of you on the phone. And most cities or many cities are really bookended by 2 systems. Like I liken it to CVS, Walgreens. You build a store, I build a store. You build a store, I build a store, right? And so the system, but we have generally good coverage, and you're just picking chocolate or vanilla. In Cincinnati, there's 5 really good healthcare systems here. So blessed, I think it raises the quality of all the boats, but it does make it harder to make these kind of programs sometimes work. So from a provider perspective, it becomes an issue for us when that person shows up who either we're out of network or we're in a much lower tier network, and there's a lot more patient responsibility. Often, they might be here because it's a unique service. Okay, speak up. I'm being told to speak up. It might be a unique service, or they just wandered in, and now you've got a patient in the bed, and we don't have a rate. And so, what I would say is that it just administratively becomes quite an issue, because now we're kind of scrambling to understand how we're going to get paid, who we're going to get paid from, what that person on that side.
I'll add from Tri-Health's perspective, I think our lens is really around a couple things. One is from the provider side, is we want that coordinated care. We feel very comfortable that when someone comes into our high-performing network, we're able to coordinate that care, coordinate it seamlessly, and the quality is just a better output. that transcends into the patient experience, which is a much higher, greater experience. They feel like they're navigated flawlessly. They feel like they're getting the best of the best. And so for us, that high performing network is not just only Tri-Health employed individuals, but really the partnerships that we have within our network that allow us to bring the best of the best together. So the cost does become an output of things, but the quality is really what is driving it. And the provider at the physician level feels really good because that primary care physician can really quarterback the care and ensure that that individual is getting what they need.
So that actually speaks to a positive or enhanced patient experience.
Yeah, and I think that the employers have to help their employees understand the benefits that they will get from an enhanced experience. And that would take the stigma off of being in the narrow network. I think our employers would be hesitant to enforce that or move in that direction. But if they could, the health systems can help the employers sell that to their employees so that they're comfortable with selecting that as a product too.
I was just going to emphasize, and it's been said already, but I think it's worth emphasizing, and a lot of what I see in my team sees are the things that sort of go wrong, and sort of the big things that go wrong. And to what's been said already, I would just emphasize to the group and those listening in that if you go this route, be transparent. Be transparent up front because there's going to be a handoff issue. You're going to have patients who maybe were treated by one health system, and now they're going to have to make that change. And then the other thing, just as you go down the road, but both transparent to your members and transparent to the healthcare system. And I think that the second part is probably easier to say than to do, but I know what happens in my world, and we see it often. I saw it yesterday. We have a patient who's scheduled for a surgery today. 3 surgeons, tumor. This is a young person who's dependent on a plan. Excuse me, and we want to be all narrow network. Are we in network? Are we not in network? This is, we business people, we think, are we going to get paid? But is this person going to get a benefit? How's this going to affect this individual surgeries today? And the conversation was last night at 6 o'clock. So, and maybe there's a lot going on there, and maybe we have a piece of that, but those kind of things happen. And so that's first and foremost to me is what you want to avoid as you go down this road.
And that's a very stressful conversation for that patient and a very stressful time of their life.
Yes.
So as you think about shifting from a reactive or the old world of this is happening to us from a payer's perspective, and all of you are taking proactive steps in one form or another. You speak to what those steps are, lay them out on the table, what you've explored, what you've moved forward, what you haven't moved forward, how you choose partners, whether it's a TPA partner or direct contracting employers. We'll just throw it out there. See some heads nodding, so jump in, whoever.
We've been open to everybody. That's been my mantra because we occupy 10 counties, pretty much the only system in 10 counties. If you want to come and establish a product in my backyard, I'm happy to have you. And we've got similar contract terms for everybody that wants to come to that space. So that's number one. I think we've been very welcoming and let the market sort out who's good at this, who's bad, who's got good benefits, who doesn't, who processes claims correctly. Fine, let the market figure that out. Our part in all that is to commit to you could have my system at the same rates we offer everybody else. And then as I set rates, I've set them so that a group, let's say Care Springs, if they join or they don't join, my business is going to suffer. We've priced it so that if I get a little bit of extra business, it pays for the extra discount that I'm giving. So as a health system finance manager, if this explodes and becomes the way we produce care, fine. And if it doesn't, okay, that's fine too.
So I got a point of view on this. So when I think about narrow networks, I think of it in 2 different ways. So one way we think about, if you sit at the table with a large employer or a self-funded employer, and you're going through the annual reports and you're looking at, how much did I spend? Where did I spend it? What did I spend it on? And typically in those reports or in that annual review, you're going to find what your top cost drivers are. And in most cases, it's probably the following 3. It's oncology, it's cardiovascular, and it's musculoskeletal, right? Those in most employers, those are your top drivers. I mean, depending on the group, it could be a little bit different, but at least 2 of those 3 are going to show up as the top 3. So there's a way to look at that in terms of the narrow network, because those are your cost drivers. And so what we've done at the Christ Hospital is that we've developed centers of excellence, bundled products to take to those employers to address that spend. Because when you ask an employer, say you spend all this money on orthopedics or cardiovascular or whatever, how do you feel about the ROI on that? Feel like you've got really good outcomes, you get good results, feel good about that, because you measure everything else in your business, right? And when you talk about that, it's a blank look because they don't know. They don't know how those procedures work. They know they did them, they know how many they did, they might know what they are, but they also don't know the cost variation. Because cost variation can be huge. There was an article in the Wall Street Journal last week that talked about the cost of musculoskeletal procedures in Indiana. They're probably twice what they are here, right? So, and if you have an employee, if you're an employer, people over.
Tells me I need to get the Indy market.
Yeah, exactly. So at any rate, so we have a solution where we're, it's a single price, with warranties on it, single bill. So it addresses one aspect and the major aspects of their health spend. And so that's been highly successful for us. We have probably 300 companies who now participate in centers of excellence, and we do it with orthopedics and cardiovascular. So that's one narrow network opportunity that's been very successful for us. The other is the more traditional about creating a health plan that features one of the systems. So in this market, I would say it's not really a narrow network. I think it's a tiered network because it's next to impossible to get a narrow network in a market like this where you can exclude everybody but one system because things are so bifurcated. So somebody else has to be, part of that system. So we have launched our own health plan in that space. It's targeted to employers from 2 on up, and it's all in a funded basis, so either level funded or self-funded depending on your size, and it creates steerage towards the Christ Hospital. The reason that's important is because at the end of the day, in my view, these narrow networks are only worth doing something to manage trend. Otherwise, what you've done is just have a 1-year buy down because of some pricing reduction. And you can't come back to the table and say, show that we've actually improved the health of your members. Okay, then it's not worth doing. And I would contend that the carriers can't do that. Okay? They can give you all the data about what was spent and where it was spent, and they'll connect some dots that may or not be connectable, but they'll assume that certain things around quality. But they don't have the EMR. They don't have Epic. And so when you deal with a system directly, you can have, and I think it should be changed the dynamic of healthcare, where at the renewal meeting, it's not just the carrier and the benefit consultant and the employer sitting at the table, but it's also their chosen health system. And the chosen health system is talking to them about population health. I said earlier, the secret sauce is around primary care. So what needs to happen is to create as much steerage towards the primary care, because that's where we can really get into it and influence those members. We find when we have all that information, you get the primary care doc involved, really high participation in space. And so that's what we've done, like some others around the table. We've done that with our own population. We've been doing that for 8 years. And we've kept our trend minus pharmacy, at about 1% over that period of time. And the last thing I'll say, at least in our model, we do pay docs for the outcomes. So again, let's all remember the healthcare world, it's RVU based. So systems, docs get paid for doing stuff, right? I think the model change that we're seeking is getting paid for doing stuff right outcomes. And so that's what our focus is, and that's kind of the vision we have.
I would say for us, we look at it a little differently in that we're really about, when you ask what are the hallmarks of the partners that we want when there's a pay or carry, it's really around innovation. How do we bring this innovation to what we're doing from a care delivery perspective? In our world, it is really managing total cost of care. So we have our primary care, which is the largest in this community from a network perspective, really understanding at the physician level what needs to be done to manage utilization in the appropriate manner. And then they're marrying up with our specialists. And so our system chiefs at the physician level get this. They want to do the right thing. They are on board with having aligned incentives, as Kim alluded to. So compensation has changed so that our physicians understand that we're moving in this direction of value-based world of capitation again, and not just getting the widgets through the door. But at the end of the day, our primary care, our specialists want the right quality for that patient. And that is just driving everything. So our clinical pathways have been focused on so that we can get rid of redundancies, get rid of the waste in the system, and truly manage utilization and total cost of care. And that has worked really, really well for us. We have almost 300,000 lives in a value-based agreement, of which almost half are on a partial or full-sided risk arrangement. So we're kind of putting our money where our mouth is, and similar to how Christ is doing, we've done this with our own population, and we're seeing very, very minimal increases on a year-over-year trend.
The one thing I think just to interrupt and add, so at the Christ Hospital, again, it's probably the same around the table. We heavily incent our employees to stay in the system and domestic spend, and we've been very successful doing it. So about 70% of our members have a primary care relationship with the Christ Hospital primary care physician. And so that, again, because that's the quarterback, that makes it work. So I guess, I think it's a multi-year journey as employers think about a narrow network, because I think we've got to nudge, push, shove, and I think a lot of it depends on having the employers willing to stand up and say, our healthcare partner is the Christ or it's TriHealth or whatever flavor that you're choosing. And we've chosen them because we think, they bring innovation, they have the best quality, and whenever you can make a decision, in your healthcare towards one of those systems, I think you should do that because it will help improve our health and it will help us to manage our costs over time. But in my view, the employer cannot be absent. It's just the flavor of the day. We're doing this for this year because this one's going to save us 20%. And we'll probably be a new plan next year. Save yourself the trouble.
So I'm interested in, I think probably to some extent are behind a little bit in some of the other systems. I would say that in that, as we started talking about value-based payment years ago, we were really interested in episode payment, and we really sort of took a look at episode payment for more complex conditions, which is everybody really understands why that's so difficult. And we had some experience with that, as I said, through cell organ transplant. But we have for a number of years been participating in the programs. I think that you're all participating in the CDC type program, Medicare, Medicaid, and some of the big managed care plans have programs that look a lot like that. And what I think is sort of interesting there is that, there's a big, from my perspective, obviously when you're dealing with the federal government, it's one thing, but in any event, there's a big administrative hurdle there to put all the resources that you need in place to be able to manage. What I've seen from our experiences is that we've done a really good job closing care gaps and doing that kind of thing, which is a great thing. When you start talking about total cost of care and managing total cost of care, Tim, as you said, you've got a lot of the data, but you don't have all the data, and you've got to really have a close working relationship with that managed care plan or the third-party administrator to be able to understand costs that are being incurred outside your system. And that's easier said than done. I think we all probably have experienced the issues with just attribution. What docs are a part of your network, in the system of the third-party administrator. There's problems there. You get patients attributed to you that are yours, and just having the administrative capacity to sort all that stuff out and get it right. And I think it goes to what Tim said about, it really does need to be a longer term relationship, because you're gonna go through kind of growing pains early on to get the system set up and get the sort of data flowing and get that understanding in place. And probably as you go along, you can scale it up and be a little more efficient at it. Still, I think every one of those relationships is probably to some extent unique. So I don't know, I'm interested to hear what other people experience in around that. That's kind of what I see where I am.
And we run into that as well. And because of those administrative burdens, unless the employer is of a significant size and has a number of lines to give you, you're really locking out the small employer market from participating in a true total cost of care type of arrangement. So at least initially, we offered our direct to employer option to the market to at least offer a care coordination fee and get them accustomed to, navigating the health system, how we can help them reduce their cost over time. But it almost seems like the smaller employers will have to get to a group purchasing model to truly participate in a total cost of care arrangement if they're not willing to go with a national payer.
Yeah, I just, and I thought the answer too, in talking about episode tenants, that, as we've looked at that, and we've done some of that, but, to me, for a specific employer, or even with a specific managed care plan, depending on what you're talking about, to have numbers where you're going to have some predictability as to the spend, I think can be a challenge. Some of the ones that we've looked at, there weren't all that many sort of episodes, procedures, I suppose, or chronic episodes where you had sufficient numbers to feel like you weren't going to have, you've had some predictability as to results of it, would be part of that challenge.
Well, I think just to answer that question real quick, I mean, for us, it's been mostly around orthopedics where we're very high volume, and then we also limit who gets to do them. So it's not all the, so with its quality profile, really the best with who've got quality managed the cost, and so they get, those are the ones who get the patients. And so we've been able to do that. It's joints, backs, and shoulders right now. And we've just kind of wandered into the cardiovascular space, and we've got to be selective because some of those things it's just really hard to predict. A lot of people like to get in the oncology space, and there's just no way that's happening anywhere. I mean, that's completely off the chart. So I'm, but I think maybe the point though, I think they're great efforts, and whether that's the right solution or not, I think it's kind of where people are. But it's starting to move, and what I like about those kind of programs is that when an employer starts to get involved, you start to talk, we move the conversation to quality. Because in the past, again, back to Bill, our days at Humana, all anybody cared about in those days were it's the discount. And I'll exaggerate a little bit, but we didn't really care what the rate was as long as it was less than they were charging somebody else. That's not exactly true, but it's directionally correct. Yeah, because at the end of the day, the decision was made based on discount analysis, right? And so that was the only thing that mattered. And I think what's really starting to happen in these programs and the employers you could talk about quality, but no one knew how to think about it. The data wasn't there to support it. And that's, I think, is kind of the cool thing that's starting to change. And so if an employer does, you might say, well, knees and hips, or it's not going to move the needle. Well, it will move the needle because you're going to save some money, but it's not going to completely change the trajectory of your health plan. But what it also starts to do, I think, is it starts to create, if the employer is saying, we've implemented this program because we think get the best outcomes, and here's the proof. It gives people thinking about that they're, it's, maybe this is where I should have it done, not because my neighbor told me he just had it done somewhere. So people make bad decisions, and I think it starts to raise awareness around quality.
And I may be a little naive as I'm just listening to this, but I feel like, at least at TriHealth, we have this as part of our DNA, where we've been able to, through innovation, eliminate administrative burden. I think it's a great point. It's such a barrier, but we've been able to eliminate that. And it's just who we are. It's just the care. So for us, it's respectfully not a program, but it's just how we deliver care to our patients. And so that, I think, has been maybe a little bit different for us in that we just have weaved this through over the last several years as just part of how our physicians think, how part of our nurses think, and it just becomes how we deliver care.
So on the partnership aspect, I know, Bill, you shared you're open to talking or contracting with any participant who comes to the table. All caveats. Good. I know there's been other paths chosen by different systems in the room. Terry, I know TriHealth has a product offering with Anthem. Can you share how that came together and why you chose Anthem? And then we'll look for alternative use for the other systems.
Yeah, I'd be happy to. So when I talk about innovation, they came to us and said, we're looking for something creative. We want to make sure as employers are out there wanting cost reduction, we want more than just cost reduction. And I think we're the third largest employer in this community. We've been piloting a lot of things within our own world. And so we really like the concept of innovation and being able to eliminate administrative burdens and be able to think of how can we deliver care in a different way that's going to net not only the big companies, but also that mid-sized market, because we're in a community of a lot of mid-sized markets. And so we do have our Blue Connection offering out there, and it is where we kind of put our money where our mouth is. We are at risk if we do not get to a certain outcome for that employer in terms of their savings that we know that they can get. And so we're very committed to ensuring that we're managing that patient. It's not only on the financial side, but it's on the outcome side, and it's on the experience side. So because of all the work that we've done over the last 20 years of Pop Health, we just felt ready, and we've had some really great success. Just this past year, I think we've had a 200% increase in how many participants will be in our program for 2022 and using our high-performing network. And our high-performing network, and just so everybody's clear, is not just TriHealth, it also encompasses other entities across this region. So it is a combination of 1,200 plus providers that are both employed by TriHealth and affiliated with TriHealth.
Tim, I know you talked a good bit about bundles and the episodic piece, and that, my understanding, is really administered by Christ himself. You've also talked about the health plan product that's coming to market.
Yeah.
How did that come together? How do you choose a partner there to make sure that they're the right fit for your patients?
Yeah. So much like Terry said, that one of the main components or decision points was innovation. So we chose key benefit administrators at Indianapolis, the largest independent TPA in the country, and we were very impressed with their administrative capability and some of the product enhancements that they incorporated into it. So it's highly transparent pharmacy benefits that create lower costs, and there's some other assisted programs that help really drive lower costs for employers. The drugs can be obtained at much lower pricing. So that was a big thing. I think the other thing that really drove us is the market size that we're interested in participating in. They're willing to go down to 2. And there's funded products in that kind of that 2 to 50 space. You have to be really careful. Don't want to call take this wrong. So there's lots of guardrails and bumpers there. But as you get a little bit larger, more data, and this is all funding. The point I'm going to want to make, though, is it's around the reporting that the employer gets. Carriers are very stingy for employers in terms of, especially on the low end of the market. What do you get? You get any experience at all? And if you do, depending on your size, it might be very generic. That's not very useful to you. And so you've spent all this money and you don't really know what happened. So I think what we like about key benefit and our offering is it provides much more reporting capability that can get much more granular. So you can really start to dissect what's going on within your organization. The other thing that I would say, and one of the challenges of narrow networks is that you can be based in Cincinnati, you have a lot of employees. What happens to my Louisville? What happens to Indianapolis? What happens to? So I've got some folks that I really don't like having different levels of benefits. So this is part of KPA's business model is to build select best in class partners in the markets that they're doing business in. So you can kind of, I use the word daisy chain those together. So similar but different in different offerings at different markets. And so their goal is to have 23 to 25 of these within the next year. So again, it just creates a level of seamlessness for the employer. So, and then last thing, so and then we incorporate some of our other stuff into this. So like the Center of Excellence can be a small care product. So,
Bill, Tim, Billie Jean, I don't want to force you to highlight one if you want to be neutral on some of your partners, but what do you use opportunity?
And I don't want to ban out any of our partners, but I do want to raise the point, as Tim was engaging with key benefits, one of the things he's going to look at over the arc of that product's life is, am I gaining market share? Am I, he's giving additional discount as we have with, the promise is I'm going to get additional market share. I can tell you that over the past 12 years doing this, we have not been able to measure an increase in our market share as a result of these products. That's kind of a problem for these products because it signals maybe either the market doesn't really want to buy these. It's still less than 3% of my commercial volume after 12 years of trying to do this. And each of these systems here is going to have a certain appetite for doing this that is going to be predicated on, Am I gaining market share? Am I helping the company grow? That's a real concern of ours. And if you're not selling, or the way you sell isn't really appreciably growing your market share, these programs can't work long term.
Yeah, I guess I would just say, I mean, a couple things. You know, I mean, we participate in all kinds of value-based payment programs, which are mostly sort of upside quality and incentive kind of programs. I'm sure everybody does. They're all the same for all the same folks. On the sort of the primary care pop health programs, I think that Anthem is sort of the most advanced approach, at least what they take to the market. We participate in that program. And, you know, I think it's been a good effort and a good relationship. I think there's still work to be done, particularly around total cost savings and some of the things that I talked about. And we've also done some partnering with them around some specific episodes of care. And, you know, it goes back to what I said before, sort of, so they've got sort of a smorgasbord of episodes that you can sort of pick from and participate in. And one of the challenges we saw there was just volume, just episodes of driving up volume that you guys are able to do. But those have been good relationships. And then otherwise, you know, we've done a number of the CMS programs, the oncology care model and primary care first. We're involved in that. But we haven't been driving any narrow networks other than our health plan is tiered. But other than that, we haven't been in the business of really trying to drive narrow network products.
Hey, just one comment I thought. You know, what's kind of funny in this business is kind of, you know, what's old is new again at times, right? And so by that I mean, you know, when I started in the business 100 years ago, you know, there used to be slice business, you know, like each of us would slice it into an organization, different ways to, you know, to manage that benefit for the employees. We're starting to see some evidence of that again. TriHealth just has an offering with major in Cincinnati, where that's part of their offering. We're working on a couple of opportunities right now with some big employers with the product that we have that they're looking at in a slice manner. So that just means it becomes available. Still get to go home and choose this one. You're committing more to that system. So it's just interesting. Will it take off? I mean, is it? You know, I don't know, but I think it's at least interesting that it's in the discussion again.
Yeah, well, I think COVID has driven some of that.
Yeah.
You know, with COVID, the impact on customers and employers, it's just really hit the financial line.
Yeah.
And so we have to be thoughtful on that. The other thing that I don't want to lose sight of is just the clinical quality and the fact that we are not in a healthy state. Our region ranks really poorly across the nation in terms of health outcomes. And so while we're looking at this through also a cost lens, at the end of the day, employers have such a voice that we want our employees and their family members to be healthy. And if they're healthy, then our community can be healthy, and we don't want to lose sight of that.
I do wonder right now with the labor market as such, if you know, narrow networks will, you know, be cool for now. That employers will be reluctant to go in that direction.
That's a great point.
Yeah, along those lines, you know, it's very short term. Let's hope it's very short term. But I do wonder when we talk about, you know, sort of discount for volume. I think all the systems are at capacity. You know, I mean, you know, we had discussion about volume, and you know what I'm hearing from our folks is we can't have a volume guy. And I think a lot of people are against it. But that's short term. I would expect it. It is an aspect, you know, currently.
Let's put a lid on the health system conversation for a moment and turn to Chris.
Yeah.
So you shared that you offer a narrow network solution to your employees. Give us the history of how that evolved.
Yeah, so-
what the experience has been.
Yeah, so we're self-insured. We've been self-insured for 15 years. We have over 2,400 team members and over 1,100 lives on our health plan. And so, and we've added a couple buildings the last couple of years. And so, since we're the largest skilled nursing provider in this region, our aim has been, because we have to partner with the hospitals for patients, but also for our staff. First, it was access. So like 6-7 years ago, our costs kept going up incrementally. We're self-insured, but we had more of a traditional PPO network for our staff, and a couple different tiers within that, with what I felt were higher premiums that some of our staff can afford. We've always looked at how do the premiums compare for a nurse aide, and can they afford to pay them? And so with that, 6-7 years ago, we started looking more direct contracts. So we first started with many of the people in this room geared towards having zero deductible, having pretty much no copays, trying to aim for preventative. So preventative, take care of yourself, go to the doctor. And 5 years ago, we added $100 if you go get a PCP and you get a physical every year. We pay them because we want people to go see their doctor. Let the doctor steer them where they need to go. We're making sure their needs are being met. So the transition itself was just a lot of education, 1,000+ people educating them. Like, we've given you flexibility. We're not saying, and we're being fair. Like, so if you're in Northern Kentucky, most people go to St. Elizabeth. If you're in Cincinnati, you're in Christ or Tri-Health at the time. And then Kettering was something that was in the infancy, but we, like you said, we bolted on something with Kettering so that people in Dayton had a choice. We also educate, if you go outside network, like anything, you could have to pay more. And just sitting down and educating them day one, and providing the flexibility that hopefully people didn't have to switch a doctor or switch to another system altogether. So early on, we added also a Teladoc, which is a telehealth platform. And we bolted on some pharmacy cost savings, all aimed to keep the cost down for the team member. So it really wasn't a difficult sell. What was difficult was managing when someone doesn't follow their network, making sure the providers get paid accordingly, and making sure our staff don't get balanced bills, because we don't want people to get balanced bills. And I know no provider wants people to get balanced bills because you're not getting paid. So trying to minimize balance bill, can we negotiate through our TPA if and when that happens? That many times we end up paying the difference as a self-insured payer. So it's pretty much, it's helped keep our costs off that massive upward trajectory we saw 6-7 years ago to more flatter. Some years it goes up, and like you said, you can have we have a stop loss carrier, so that as a self-insured payer, if they go over a certain limit, stop loss carrier kicks in. So you have those couple people, you know, some years it's zero and it's luck, it's just luck. And you have other years where just unfortunately people are sick. And my concern with COVID is that, like, you know, you have 2 years where people aren't doing the preventative things like they should have. And now these things are going to start cropping up where someone has cancer, which just happened, and other things are going on with people. So the transition, I think, was globally successful, but also we aimed that we haven't really increased our premiums hardly at all to our staff for the last 4 to 5 years. Part for to maintain staff, part to go to that, but also the thing we're failing on still today, we don't educate on how good a benefit we have. So every day, and I'll literally, I have a weekly CEO call with the buildings. If they want to ask any questions. And one of the things I always talk on every meeting about the benefit of our health insurance and why we spend more so the team member pays less, because we want them to take care of themselves. And many people in our industry are just like anybody in the hospital, but then we have a large swath of people who just don't take good care of themselves. And we don't understand the benefit of going to a doctor, and they want to go to the emergency department. So early on in this thing, we could tweak it. Like, if you go to the emergency department, it's a $350 copay. You shouldn't go to the emergency department unless something's really bad. Urgent care, we made like $40 because I'd rather you go to urgent care than go to the emergency department. And if you go to your main doctor, they pretty much don't pay hardly anything. And so we're trying to gear towards the primary care doctor. We're trying to gear towards that preventative medicine. Make sure they're aware of all the things that are free if they follow that program. And also educate people that, you know, if you have kids, you know, it's pediatric network is within the network. You know, it doesn't have to be a Tri-Health affiliated or a SAME affiliated pediatric, because most people goes, and we work with Christ Hospital or Children's Hospital. They're a little more expensive, so but they're great now. What we do is with Children's, you know, we don't have a direct contract. We just negotiate based on their cost, and we try to educate people. Every system here has a pediatric arm, and many things can be dealt with at one of these institutions, pediatric networks. Go to them. If you have something major, I'm never going to say don't go to Children's. Go to Children's. I'll go to Children's if something major happens. So educating them that we're not blocking off their access, but giving them the flexibility, but also the responsibility that if you go to the emergency department for some very basic thing, you're going to pay for it. You're just educating them on, if you go here, this is what, and it seems so basic. I'm sure you have it in your systems as well. You know, you have to make it very easy to understand for all your team members so they know where to go. So the benefits have been it's kept our costs relatively flat over the last years. We've not passed any cost increases we've eaten as a company. And we can't really afford to do it, but we really can't afford not to do it because we need, and always need the next generation of caregivers in our settings. And so I would, go ahead.
I was saying, you mentioned two really good points.
Yeah.
One is just educating team members.
Yes,
I mean, really getting them to be good consumers.
Correct.
That's such a concerted effort.
correct.
The other is changing behaviors. How do we get at the core of helping people change behaviors? And that's part of a care delivery system's
Absolutely.
responsibility.
And I think just, yeah, and I think just with our staff is just educating, these are good quality providers. And some people don't like, a lot of people don't like change, but you know, at the same point, is if you went with Dr. So-and-so, then stay in that, go join that network. So we try to have accessibility that it didn't always cause the person to have to leave their current hospital system by having that choice. Yes, it'd be great if we just had one building right next to Christ Hospital, like, we'll just, everyone should go to Christ, but the reality is we have people in all of our, no, but in all of our 14 counties, and we have people up in Clark County, Miami County, way up north, and we have people down in Pendleton, Bracken, you know, even some in Gallatin down south. And so we have, and in Indiana, so we have to have the accessibility for all of those team members so they don't, because then the people that are the good consumers look like, I'm not gonna work for you because I don't have access to my so-and-so. And so like, we have to be flexible enough to make sure we keep that in mind. We never want that to happen, but also we want to be good partners with all the hospital systems. But I think at the end, every year we make a big push, like our open enrollment's in May. And so we make a big push every year right around this time of educating where they are, what they're paying, what their total spend is. And I know everyone does it. And this year we're making a point, every single person, we're having a one-on-one conversation with every person who's on our plan, any new hire who comes on. And then we have people that do it, but I don't think they get the benefit that we're offering and making sure we're helping them proactively take care of themselves. We can all take better care of ourselves, like doing preventative stuff, cost will go down. And it's proven generally to work well with us. COVID's a huge wrinkle I'm really concerned about because people haven't been going to doctors and seeing their practitioners timely. So some of our costs went down, we're like, oh, the costs are going down. Now it's going down because people didn't go to the doctor. So, no, but I tell anybody on the call is like, you should look at a narrow network because if you're enough scale, if you can do self-insured, I know there's some risk with that. Some people are risk averse, but that was one of the best things we did 15 years ago. And going forward, going more narrow network and looking at what's out there every year, but not switching every year. I agree with what you said. We've been with the same general program. No, we might add a program. We might bolt on a pharmacy benefit. This year we're looking at, can we get drugs internationally, if that's permitted for our team members that are high cost drugs, looking at paying for those benefits, which will pay for themselves and lowering their costs in their team members. And also making sure our team members are having struggling, I still don't pay the bill you get from the hospital, but just pick up phone and ask a question first. And there's some people who just aren't educated consumers, like, oh gosh, I have a $5,000 bill from the hospital. Like, you max out of pocket, not that much. So why would you? But they don't understand that. And so, so just trying to make sure we're doing everything we can to make sure people understand the benefit or utilizing the benefit and rewarding people who benefit. We also have a wellness program where, you know, smoking cessation discount on the premium. We're actually, I asked a lot of people in the hospital, what are you doing? Like, you know, do you have like a COVID discount if people are fully vaccinated with COVID? We're required to be vaccinated, but 85% are. But should there be an add-on for people that aren't? For what? I don't know. It's just a controversial thing. And people are sick and tired of COVID, so I'm probably not gonna do anything with that. But and I also don't want to shrink our workforce because someone inadvertently gets frustrated by it. So, you know, you got to, so I'd recommend anybody who has enough scale. What I don't know is, I'm not the expert, like at what point does that make sense to an employer? If it's 2, if it's 10, you know, there's other nursing facilities who have one building, but they have 150 team members. And they're like, I can never do self-insure, or I can't do some of those things. Like, and I don't know the answer. I don't see why you couldn't. Talk to the hospital, maybe do a direct contract, get CPA to do a direct contract with the hospital, see what they're willing to do. Because I venture to think people are more willing to be flexible than ever. So,
I agree, and I think your point of prevention is a good one,
Yeah.
because like in our world, we integrate our corporate health service offerings into our network offerings so that we can make sure we're getting people as far upstream as possible. The more we can prevent, the better the cost savings is on the back end.
yeah. Did I answer all the questions?
Yeah, that's great. A net positive review for neural networks, roll it all together. Sounds like there's a lot of.
And in my world, I'm also used to, I'm a skilled nursing provider, so we admit and discharge 6,000 to 7,000 patients a year. So, Price has specific, preferred networks. Everyone in here has preferred networks of what's it look like to get our patients. So we got to do, so we're already accustomed to understanding what that narrow network as a quality provider means for the hospitals and for our patients. It piggybacks off on our staff the same way.
So no increases to the employee cost over the past 4 to 5 years. That's pretty impressive. I think a lot of employers would be very happy with that.
Yeah.
So that's a positive.
Yeah.
You mentioned some of the noise or the reaction of the employees when you made the switch. Is that tapered off over the past several years?
I think people are just, we have, of our 2,400 team members, probably 900 to 1,000 have been with us 5 years or more. So they know what we had before. And so what I just do for people that have no perspective, I show the out-of-pocket expenses premium per month when it was $300–400 a month, and show what it is today. And it's significantly less. So you squash any questions and when you go to my thing is I say this confidently, go work in a skilled nursing facility. I guarantee you're not going to get that benefit. And we're willing to pay, so they're going to pay you $1 or $2, 50 cents more than $1 for your job. I guarantee you're going to pay more on your health insurance over there. I guarantee it. And so we spend money on the front end to try to keep people healthy, well, and with us long term.
Awesome. We have some questions in the chat, but just one final question for you, Chris. So I know you're a client of USI, which thank you for your business, but what TPA partner are you working
We're a custom design benefit. So I would say we're a very loyal company. Our aim always assessing, evaluating what's best out there. So, I lean on people like USI and say, what's new and innovative out there that we're just not doing, and making sure our TPA or whomever we work with is staying on top of those things is really important, because we want to be cutting edge and innovative, not just for our setting, but for all healthcare.
Victor, questions in the chat?
Yeah, great questions. Greg Alexander is asking about pharmacy costs as employers, caregivers, and risk-bearing entities. What strategies are working?
If I could say something.
Yeah,
We bolted on a couple things. One is a thing called paid health, which allows people who might qualify for a financial benefit to get, say, a high cost med, say it's $100,000 med, and there's a discount, whatever it comes down to, we pay our amount and they pay their amount. So instead of it falling on the plan being $100,000 spend, it might be a $20,000 spend. And we have RX results, which basically, if a team member gets ordered this medication, they look at it and assess, is this evidence-based, the right medicine at the right time for the person, or have they gone through the proper step therapy? Whereas the person that instantaneously having this new diagnosis, and they're instantaneously getting put on the highest cost med day one, making sure they're going through a step therapy that is the most beneficial med for them. So it's not a goal of delaying anything, it's just making sure at the end of the day. So, and also there's new brand drugs that come out every day. There's one called Trimexit that came out several years ago. My wife has migraines, and it's basically naproxen and it's Imitrex. Two things you can take separately that cost like $3, but they put it together and they cost $100 a pill. So our plan says, no, take those two pills separately and you'll be fine. And so those type of things help keep those. Yes, there's still some other catastrophic.
And I would say from the provider side, we do similar things in our health plan, but from the provider side, we actually have a group of pharmacists that work with our patient population from a population health perspective, and they're doing exactly that. They're looking at polypharmacy, they're making sure that individuals are on the right medicines, they're consulting with the physicians to say, do not prescribe this because it's going to cost $1,600, but you can do it for $200. They're looking at biosimilars versus biologics. So there's a lot of initiatives around pharmacy that just help lower the cost of the drugs.
Precision medicine also factors into that, with some of the genetic stuff that helps to kind of shortcut the choosing the right meds. And that's a whole other discussion.
Yeah.
That's
You're right.
that's an important component that I think will help. I mean, it's a glimmer of light, but pharmacy is still very complicated.
Do we have time for another question?
It's one more.
One more. So this question is actually a great question to introduce our next in the series of innovation panels, and this is about wellness. Do
30 seconds.
you find that company-sponsored wellness programs are well received in your system? Do you incentivize your employees or to participate in what works?
Yeah, I'll start that one. For us, we've done wellness for decades, and it actually does work for us. We incentivize, but we use data to figure out where our pain points are. So for example, if we don't see enough women getting their mammographies, and we know that we have an issue on that with our health plan data, we'll heavily incentivize so that we can get more women getting their mammograms. But we've done this for decades. I would say for TriHealth and for the companies we serve, we have seen a lot of great success in terms of using wellness programs. If you're using the data correctly, incentivizing correctly, and really getting to ultimate sustainable behavior change, because that's what it's going to take, is we've got to get into sustainable behavior change.
Yeah, let's just use the data. Too many companies, you know.
I keep forgetting to log my hours.
Yeah, you're right, Tim, you gotta use
Yeah,
the
you have to
data.
use the data and create the plan. So all of us are probably in that space one way or another.
Yeah.
But if you know, if it's just an exercise, you put it on a shelf, and everything, that's true.
Thank you. We're at time.
We're at
Do
time.
you want to
So
wrap up?
thank you all for your participation today. It's great conversation, great energy from all of the participants. We will be regrouping in 2 months for the next session. Is that right?
In May, and we're going to be addressing wellness and well-being. We're actually going to talk about innovation, because we really do need new ideas in this space. So thanks for joining us, and have a great day.
Thank you.
Thank you, panelists.
Thank you.
Thanks.
Thank you.